US sponsored symposia by Pfizer. We are going to discuss in the next hour about the patient unmet needs in polyarticular course juvenile idiopathic arthritis, and in particular current challenges and future perspective. I am Nicola Ruperto. I am a pediatric rheumatologist working at the Gaslini Children's Hospital in Genova, Italy, and I'm the scientific director of the Pediatric Rheumatology International Trials Organization. These are my disclosures. It is now my pleasure to introduce the faculty of this symposium. First of all, to young and promising researcher, Alessandro Consolaro from the University of Genova and the Gaslini Children's Hospital, who is going to speak about the assessment of disease activity in JIVA. Then Dr. Flora McCurley from the Newcastle University and the Manchester University. She's an expert particularly in adolescent medicine. And Professor Lovell, who does not need any presentation, is the chairman of the Pediatric Rheumatology Collaborative Study Group working in Cincinnati. Dr. Lovell is going to reach us for the question and answer session of this symposium. So what we are going to do in the next hour or so, essentially we will have three main objectives. The first will be to explore how we evaluate the disease activity status in children with polyarticular course JIA, including this discussion about the clinical feature, diagnosis, and how to measure properly disease activity. The second talk will be more related on the patient perspective and the related unmet needs in order to try to optimize as much as possible the proper management of polyarticular course JIA. And finally, we will concentrate on the therapeutic options which are currently in the developmental phase, including JAK inhibitors for the management of JIA. This is our agenda for today. I'm going to introduce each speaker one by one, but I just take this chance to remind all of you that in the right part of your video, you have the live question and answer function. So feel free to send us your question while the presentation are ongoing. We will take care of all of them at the end of the presentation, and we'll try to answer all your questions. Thank you. Okay, let's start with a brief introduction about this concept of polyarticular course JIA. I'm sure you are all familiar with the 7 categories which are depicted with the ELAR classification criteria for JIA. However, today we are going to speak about this concept of polyarticular course JIA. This is a functional concept which was brought forward for the first time by Dr. Lovell with the Etanercept trial, which essentially group into the same group JIA categories which we normally in current clinical practice consider divine. Which are these JIA categories? Systemic arthritis without systemic features, polyarthritis rheumatoid factor positive or negative, extended oligoarthritis, but more recently also psoriatic arthritis and enthesitis-related arthritis. These categories have been grouped into the functional concept of polyarticular JIA whenever this patient have at least 5 active joints in their history, or often at the time of enrollment in clinical trial. In this busy slide, which I will try to guide through, what I would like to show you is how this concept of polyarticular course JIA has been implemented in the phase 3 clinical trial, which has been done in the last few years. As you could see here, the first 3 drugs that have been studied were free anti-TNF, etanercept, infliximab, and adalimumab, where we still refer to the American College of Rheumatology classification criteria, namely juvenile rheumatoid arthritis. For simplicity, here in the first column, I depicted both the naming in the JRA classification criteria with the corresponding naming in the JAA classification criteria. Starting with the abatacept trial, which was done at the same time of the adalimumab, we more properly called the disease as JAA, and just as you are very well aware, there were also studies related to systemic JAA, which with drug dedicated particularly to this condition. So just a few points for you. As you could see from the second row, there has been, let's say, a shorter disease duration, especially with the last trial, mainly because of the availability of biologic agents in Western countries where all these drugs are now currently available. But then you could see from these rows that initially oligoarticular extended, polyarticular rheumatoid factor positive or negative, and systemic arthritis without active systemic have been the JAA categories, grouping the concept of polyarticular post-JAA, enrolling the etanercept, in the infliximab, in the adalimumab, and the abatacept trial. Later, as I anticipated, we had 2 drugs specifically directed to systemic JAA, with and without fever, or only with fever at the time of enrollment. But the other novelty, which started with the golimumab trial and later with the subcutaneous abatacept trial, is that also 2 other JAA categories, namely psoriatic arthritis and enthesitis-related arthritis, have been introduced into the functional concept of polyarticular course JAA. It is now my pleasure to introduce Dr. Alessandro Consolaro, a young colleague of mine working at the Gaslini Children's Hospital and at the University of Genova. I will take the lead to call him Alessandro, given our long-standing relationship. Thank you, Alessandro. The podium is up to you.
Thank you, Dr. Ruperto, for the introduction. And so the focus of this presentation is on the application of the treat-to-target strategy in clinical practice for polyarticular JAA. These are my disclosures. So where do we start? We start from a patient case. This is the story of the early phase of the disease course of a child with polyarticular JAA. Quite a user story, I would say. Julia is 3 years old. She was sent by her doctor for limping and a swollen knee. And as it happens quite often, at the visit, we found other joint with active arthritis, the other knee, one of the ankles, and two fingers. The blood test helped us to rule out other diagnoses, and at the end, to make a long history short, we made a diagnosis of polyarticular JAA. In this case, as it is a policy at our institute, we performed a multiple corticosteroids injection in the affected joint, and we started methotrexate therapy. 3 months later, at the next visit, Julia feels much better, although the left ankle was still affected, as it was confirmed by the ultrasound examination. We decided here to subcutaneous methotrexate. But 3 months later, again, there was no further improvement. Still, the left ankle was limited, it was painful and swollen. Moreover, we found also some pain and limitation at one of the TMJs. So the therapeutic choice here was to continue methotrexate, but to add etanercept in this patient. 3 months later, finally, at the following visit, we reached a complete control of the disease. No active joints, normal physical function, still some signs, indirect signs that of the left ankle problem, and we continued the therapy. And at the following visit, a few months later, still the patient was in active disease with a complete recovery and a normal physical function. At this point, we decided to taper methotrexate.
Thank you, Alessandro. So it seems that you have followed a sort of treat-to-target approach for this patient, isn't it?
Well, we will see it. Probably yes, but we will see it at the end of my presentation. So what are the recommendations for the treat-to-target approach in juvenile idiopathic arthritis? Well, you can find a definition in the 2018 paper by Angelo Ravelli and Joseph Smolin, where they first presented the overarching principle for the treat-to-target strategy in JIA. I would say that the most specific one is the last one, line F. Here you see the two pillars of the treat-to-target strategy. One is the frequent monitoring and measuring of the level of disease activity, and the second one is the adjustment of the therapy if the treatment targets are not met. Secondly, we have here the recommendation, and here we have to underline that disease activity should be measured with a validated composite instrument, and that we need, in line 6, that we need to have at least a 50% improvement at 3 months, while reaching inactive disease is required at month 6.
Thank you, Alessandro. Can you now explain which are the criteria and the tools available to properly define disease activity in JIA?
So yes, Nicola, we have multiple tools to define the level of disease activity. We have the Wallace and the ACR criteria for the definition of inactive disease, and we have the so-called Magni-Manzoni criteria for the definition of minimal disease activity. And then, as you can see here, we can also use the JADAS. There is a definition based of the juvenile arthritis disease activity score and of its clinical version, the clinical JADAS. We can define through this score the level of disease activity. The JADAS, as you know, is the first composite score specific for JIA. I don't think we need to go into details here. You all know the components of the JADAS. So you see, we have to talk about the clinical version of the JADAS. We have also a CRP JADAS version in which the ESR is replaced by the CRP as a measurement of the acute phase reactant. And we have cutoff values that are necessary to interpret the score of the JADAS. They are necessary for supporting decision about enrolling patient into clinical trials, for the requirements for change in therapy, and for defining the therapeutic goals in a treat-to-target strategy. These are the cutoffs for the different versions of the JADAS that are published. And here, aiming to obtain cutoffs that are suitable for any clinical setting, we are working on new values for both the JADAS 10 and the CJADAS 10 in oligoarthritis and in polyarthritis. This work is based on a large multinational data set of patients thanks to the EPOCA studies, and this is the big difference from the original version of the JDAS cutoff. This is still work in progress, and we are waiting for the ACR committee endorsement for this work.
Okay, Alessandro, can you tell us something about how the literature currently supports the use of a treat-to-target approach in JIA?
Yes, Nicola. The literature about the treat-to-target approach in juvenile idiopathic arthritis is rapidly growing in the last few years. And here you can see a German multi-center treat-to-target study that compared the JDAS response rates in patients with early polyarticular JIA who underwent treat-to-target approach versus some matched control patient from the Biker registry. After 12 months of treatment, the proportion of patients achieving JDAS minimal disease activity and JDAS remission was significantly higher in patients receiving the treat-to-target approach versus those from the Biker registry. The study also suggests that the advantage of early treatment in successfully managing polyarticular JIA. Here we have a North American Quality Improvement Initiative study which aimed to improve polyarticular JIA outcome by standardizing disease activity monitoring and using a clinical decision support to reduce treatment variation. The study is quite complicated, but target attestation was defined as the proportion of patients with disease activity assessment and occurred in a 77% of visit on average, exceeding the set goal of 50%, whilst clinical decision support use occurred in 45% of visit, exceeding the goal of 15%. This graph on the right shows the median clinical JADAS-10 score for patients with early polyarticular JIA and established polyarticular JIA. These data together suggest that structured disease activity monitoring and clinical decision support are associated with a significant reduction in the median clinical JADAS-10 from baseline to the final measurement.
And Alessandro, what about implementing a treat-to-target approach in current clinical practice?
Well, yes, as you can see here in the slide, the armamentarium of therapeutic options that we have available for JIA is quite large, even though some of these drugs cannot be available in all clinical settings. But as we said at the beginning, treat-to-target is not about drug. Treat-to-target is about strategy. And here, in the next few slides, you will see different treatment recommendations that, although not explicitly in some cases, they all include some kind of treat-to-target approach. Here we have the CARA consensus treatment plans. One of them is a step-up approach, an early combination treatment plan, a biologic-only treatment plan, but all of them require a tight disease control, measurement of disease activity, and adaptation of the treatment and intensification of the treatment if the goals are not achieved. So there is some treat-to-target in this recommendation, as well as there is some treat-to-target also in the recommendation of this German Society of Pediatric Rheumatology. As you can see, I will not go inside this slide because we don't need to look at the different algorithms, but all of them require disease activity monitoring and treatment adaptation if the goals are not achieved.
Alessandro, and returning to the initial slides, do you think we have followed a treat-to-target approach in the case of little Julia?
Let's let's try to see if that was true. So, as we had a physician global assessment of 6, and the well-being pass completed by the parents was 7, altogether with ESR and the number of active joints. Here we had a JDAS 10 score of 20.2. After 3 months of treatment, the JDAS score was 7.3. So, according to the treat to target recommendation, we had an improvement of at least 50% in the score. So we were authorized to continue the ongoing treatment with methotrexate. Then here we are at month 6, and the JDAS increased at 12. So here, according to the treat to target recommendation, we needed to reach the inactive disease threshold. So we didn't, and we needed to increase the intensity of the treatment, and we did it. We added etanercept to methotrexate. And finally, 3 months later, we achieved the level of JDAS 10 of 0, and this was confirmed at the last visit that I presented to you when we started tapering methotrexate.
Okay, now it's time for a little work for the audience, and we ask you to answer this question. Did we follow a treat-to-target approach in the case of little Julia? And for the audience, you should refer to the live polling tab on the right of your screen. The polling will be open for about 10 seconds, and you could submit your answer right now. Okay, thank you. The 10 seconds are now over, and here are the results on the screen.
So the answer here is probably no, because of the third recommendation of the treat to target strategy, which is probably the most important, or one of the most important. For a real treat to target approach to be implemented, we need to set the target, to select the tool and the therapeutic decision together with the patient. The decision-making plan should be shared with the patient and his family. This point is really frequently overlooked, especially in those retrospective studies showing the efficacy of the treat to target approach. And here I come to the end of my talk. As we have seen, we have the treat to target recommendation for JIA, and they suggest regularly assessing of disease activity, possibly using a validated composite tool, and adapting therapy if the treatment targets are not achieved. Importantly, as we have seen in the last slides, setting the target and selecting the tool and the therapeutic strategy should be shared with the patient and with his or her family at the beginning of the management plan. Then we've seen that the JDAS is perfectly suited for monitoring the level of disease activity over time, and the cutoff or the score are necessary to interpret the score levels for supporting decision about the enrollment of the patient into clinical trials, for changing in therapies, and for defining the therapeutic goals that are necessary for the treat to target strategy. Then we have seen that now the literature provides a few studies supporting, also in JIA, not only in adult rheumatoid arthritis, that the treat to target approach is effective, and it works in improving the disease activity states of the patient. Finally, we have consensus treatment plans from different societies that show that the treat to target approach is already part of the treatment decision making in managing a child with polyarticular course juvenile idiopathic arthritis. So thank you for your attention.
Thank you very much, Alessandro, for your very nice talk. And we will make all the questions from the audience about your talk at the end of all the presentation. And now let's move to the following one. I would like now to introduce Dr. Flora McCurley from the Royal Infirmary in Newcastle, UK. She's working also with the Manchester University. And with her, we are going to discuss which are the unmet needs in polyarticular course JIA, but from the patient perspective.
Thank you for the introduction. So I'm going to spend the next 10 minutes or so just reflecting on the challenges of addressing the patient perspective in the clinical care of children and young people with polyarticular course JIA. Measuring the outcomes that matter to children, young people and their parents with polyarticular course JIA is a necessary precursor to implementation of really important patient-centered improvements in the quality of clinical care that we can offer. With this in mind, a concerted international effort has led to a wide range of disease outcome instruments designed specifically for JIA. The majority of these tools were conceived and designed by clinicians and their teams without consistent involvement of children and their families. This leads us to question whether these tools are capable of completely addressing the patient perspective. A study published in 2009 identified that around 25% of children and young people with JIA and no clinical evidence of active disease continued to report suboptimal health-related quality of life. This suggests that these clinical outcome measures, such as the active joint count, may not be able to completely capture the patient perspective. Over the last 15 years, a number of different studies have identified significant differences between physician and parent-child ratings of pain, of global disease severity, and of inactive disease. This suggests that the physician-reported outcome measures may be equally unable to identify key constructs of importance to patients affecting them in their everyday lives. So, what are these key constructs, these key outcomes that are important to our patients? A Dutch study published in 2016 identified significantly higher levels of fatigue, of school absence, and reduced physical function in children and young people with JIA in comparison with their healthy peers. A Norwegian study, published in 2018, identified pain as being far and away the most important barrier to healthy and normal physical activity in JIA. In 2020, a pan-European study was published using PharmaChild data, in which they identified that mood swings and sleep problems were the most influential factors affecting psychosocial health in patients with JIA. A patient survey from 2018 across North America identified pain as the most impactful symptom in children and young people with JIA. This was followed by impaired function, joint stiffness and swelling, and fatigue. The same survey identified medication factors, particularly medication side effects, as a further barrier to physical and psychosocial health. So very briefly, key outcomes of importance to our patients at JIA include fatigue, reduced physical function, poor school attendance, pain, low mood, poor sleep, and medication side effects. Assessing and managing these key patient-reported outcomes in our routine clinical encounters with patients is absolutely central to high-quality shared decision-making, to ensuring compliance with medication regimes, and to improving the health-related quality of life for our patients. So, what's happening at the moment? How effectively are we as clinicians able to identify these key patient-reported outcomes in our everyday encounters with patients? I thought I'd try to answer this question with a hypothetical case presentation. demonstrate a 14-year-old girl who presented as a new patient with a 6-month history of joint stiffness and discomfort, affecting mainly the small joints of the hands, the wrists, knees and ankles. On examination, the young lady had a florid polyarthritis, and this was associated with raised inflammatory markers, a positive rheumatoid factor and anti-CCP antibodies. Diagnosis, therefore, was reasonably straightforward: rheumatoid factor positive, polyarticular pulse JIA. This young lady was treated in accordance with UK-wide national guidance. She was reviewed 3 monthly, with treatment changes made in response to ongoing active disease. She was treated towards a treatment goal of remission, with a treat target goal of inactive disease, as defined as a JADA score of less than 1. If we look here at this young lady's clinical outcome measures, you can see at presentation the active joint count, limited joint count, and ESR were high. And these reduced over time with treatment until at 12 months post-presentation, this young lady was in clinical remission on treatment. The JADA score, as you all know well, is a composite disease outcome measure designed for JIA. Interestingly, the JADA score at 12 months was not consistent with either minimal disease activity or inactive disease. So if we look a little more closely at the 4 components of the JADA score, you'll begin to see straight away that at 12 months, it was the parent global score that remained elevated, preventing this young lady from meeting response criteria for inactive disease. And this happens quite commonly in clinical care, so the parent global score is a useful patient-reported outcome measure. What it can highlight is generic concerns from the family. It does not, however, enable a more detailed exploration of the actual problem. So, if we think about this in a little more detail, we've seen that conventional patient-reported outcome measures, such as the global scores, may highlight generic concerns, but they're not able to inform a meaningful exploration of the child or parent perspective. Perhaps as a result, there is widespread inconsistency in the clinical collection of patient-reported outcomes in JIA. However, an evolving interest in this area has led to the publication of several JIA-specific composite patient-reported outcome measures. The first tool I wanted to highlight is the Juvenile Arthritis Multidimensional Assessment Report, or JAMAR. Published in 2011, this is a really comprehensive assessment of patient well-being, pain, function, and health-related quality of life. The tool has been well validated and has been cross-culturally adapted across many different countries with the support of the Printo community. It's now used routinely in a number of clinical settings, and in 2012 was integral to a study defining parent-child acceptable symptom states in JIA. By the author's own admission, JAMAR may not be able to sufficiently assess sleep disturbance and fatigue, which, as we've already discussed, are really important outcomes in people with JIA. So, as the use of patient-reported outcome measures has become more widespread, it's become increasingly clear that involvement of the target population from conception onwards is absolutely central to ensuring that the most relevant outcomes are collected. With this in mind, between 2015 and 2017, we worked with a UK-wide JIA consumer group to support them identifying key outcomes and exploring the applicability of existing patient-reported outcome measures. Our group identified 40 outcomes that they felt were essentially important. They were collapsed into 3 themes of physical well-being, social well-being, and emotional well-being. The group couldn't identify an existing patient-reported outcome that, in their words, explored all 3 themes in a condensed and user-friendly format. So as a result, we used the data we had to develop a very much patient-led, JIA-specific patient-reported outcome measure. So this is the Capture JIA PROM that we developed in the UK, and you'll see straight away that it's really short and really straightforward to complete. Far less information than there is in the JAMAR. This was very much purposeful and was very important to our patient community. The purpose of this questionnaire is really to inform that conversation between clinician and patient to help identify areas for further discussion. The tool is now being validated in multiple UK paediatric rheumatology centres and is freely available to use on the British Society for Rheumatology ePROMS website. The final group of measures I wanted to highlight are the PROMISE initiative. PROMISE is a North American initiative supporting the systematic development of new patient-reported outcome tools. PROMISE measures are designed to capture a range of different domains, including in particular physical, mental and social health. Clearly these domains are very relevant to children and young people with JIA, and although these measures are not developed specifically for JIA, a number are currently under investigation and I think show a great deal of promise. So in summary, very many children and young people with polyarticular coarse JIA still struggle to achieve an acceptable health-related quality of life, despite all the treatments we have available to us. And this is often as a result of persistent fatigue, pain, physical or emotional distress, or medication side effects. Clearly, being able to consistently collect and address these key patient-reported outcomes in our everyday encounter with patients is a really important unmet need in polyarticular coarse JIA. Further work, in careful collaboration with patients and their families, is an essential precursor to development of improved and higher quality patient-centered clinical care for our children and young people with polyarticular coarse JIA.
Thank you, Dr. McCarlin, for your presentation. And now I'm back on the podium. First of all, I have to say that I'm presenting these slides on behalf of Dr. Lovell, who at the very last minute was not able to record the presentation. So, as you will see, the slides represent the North American point of view about the potential future treatment. Dr. Lovell will be available, however, to answer your question in the question and answer session. Data published recently from two large series. The first from the Cincinnati Children's Hospital Medical Center with almost 1,600 patients, and the other from the Childhood Arthritis Research Alliance, which is a network based in North America with over 7,000 patients, clearly show that the use of biologic DMARDs, which have revolutionized the treatment of JIA, is in current clinical practice not only limited to the approved indication, but these drugs are also used off-label, as you could see from the fact that all JIA categories, including persistent oligoarthritis, enthesitis arthritis, and other, let's say, less frequent JIA categories, have been indeed treated with biologic DMARDs, either in these large case series that by the members of the large CARA network. Here you could see additional points to these regards. And first of all is that in the Cincinnati series, up to 50% of the patient, of the children, used at least two biologic DMARDs, underlying the fact that the current available treatment are not sufficient to control the disease in all the patients, and with frequency which are decreasing for obvious reason, which might arrive to more than 5 biologic DMARDs. And similar figures, even higher, are reported by the CARA registry, where you could see, for example, that up to more than 60% of the children use in their history at least two biologic DMARDs. The second concept is that there are a substantial group of patients, almost 50% in the JIA registry in Cincinnati, and almost 40% in the current registry, which are facing with a patient with a chronic condition, which is also chronically uncontrolled, raising again the concept that we are not yet in front of drugs which are able to cure the disease for all the patients we treat in current clinical practice. When these two concepts have been tried to be put in relation with the disease duration, so with the ground that the longer the disease duration, higher might be the need to use sequential therapy, both registries did not found a clear trend between the frequency of use of medication for patients with a chronic condition which is not controlled according to the current indication for the use of biologic demands. Another interesting manuscript which was published recently in 2018 look at the access to the medication that we currently have available, but also to future medication, to try to understand which were the barriers for the use of medication. Today, for simplicity and for brevity, I'm presenting the point of view of the parents, but in the manuscript, if you have time and interest, you will see that also there were data taken directly from the children themselves. So first of all, when we look in general to the barriers to take oral medication, injectable medication, or infusion medication, was represented over here, you could see that the parents in almost 50% of both oral medication and injectable medication raise the concept that indeed there are some barriers. While, surprisingly, at least from my point of view, is the concept that infusion medication are not perceived as having so many barriers like injectable or oral medication, which by definition could be taken at home. Looking a little bit more into the details about the reason associated with these barriers, we could say that for the oral medication, the major concept is related to safety over here and worries about the future consequences, as you could see over here. But also, and this is another interesting point from a medical point of view, compliance issue, meaning that there are worries about the fact that children or the parents themselves might forget to take medication which usually are given orally. When the author concentrate on the injectable medication, for sure the most important aspect was related to the pain associated with medication, which is clearly depicted over here. Again, as for the other aspect, safety and worries about the future consequences were also other barriers. While for the infusion medication, the issue of safety probably was the major one. And this again is an interesting point because, as we all know, sometimes physicians and health professionals like the infusion medication to avoid the compliance issue that we have, especially with children around puberty. In these slides, in this table, you could see the list of drugs which are currently being investigated as a potential treatment for polyarticular recurrent JAA. We have anti-TNF, we have anti-IL-6 inhibitors, and then we have also drugs which differentiate from the others, which are administered subcutaneously or intravenously, because they are available as oral solution or tablet. And these studies are mostly ongoing. few have already been terminated, and some have already been completed, and the results have been presented in prior international meetings. So let's now move to the second part of this talk, speak about this important novelty for pediatrician, that is the availability of oral medication, and in particular those which are under the umbrella of JAK inhibitors. These are completely new compounds, which are called small molecules, because they act with a completely different mechanism of action as compared to the classic biologic DMARDs that we are using nowadays. The medication are oral, and what they essentially do is that they inhibit the phosphorylation of the JAK-STAT pathway, raising therefore to reduce gene transcription and reduce cytokine production, for which we could observe the known clinical effect, which have been largely already studied in adult patients with rheumatoid arthritis and psoriatic arthritis patients, but are also now under investigation in children, as I show with the prior slides. So looking, since there are not yet so many published data about this compound, I will revise for you the trial design which have been implemented for studying this new class of drugs. The first example, because it's the only one published so far, is the tofacitinib phase 1 trial. In this case, the drug was administered to children with polyarticular course JIA from the age of 2 to less than 18, so the classic age of polyarticular course JIA. 26 patients have been enrolled and treated for 5 days, and the primary endpoints of this trial was indeed to evaluate the pharmacokinetic, to have initial information about safety, and as we saw from the barrier that parents foresee for the use of medication, also the test acceptability by the children themselves. The study design uses a classic staggered sequential approach with 3 subsequent cohorts, the first with older children from the age of 12 to 18, 8 patients, the second with younger children from 6 to 12, and finally the third cohort, which also enroll very small children from the age of 2 to 6, and the results of this study have been published some years ago. When we move to the phase 3 trial, the population, as you could see, is primarily concentrated on polyarticular course JIA, because this is the subject of all the trials, meaning all JIA categories which have as a common background at least 5 active joints, as you have listened to the prior presentation, but also because of agreement with the regulatory authorities and for observational purposes, also children with psoriatic arthritis or enthesitis-related arthritis have been enrolled, which were resistant to at least a disease-modifying anti-rheumatic drugs. The study lasted for 44 weeks, and the primary endpoint, which have already been presented to prior international meetings, was the classic frequency of patients with disease flare using the PRCSG print of flare criteria during the double blind. What I meant by double blind, now I think it is clear for all of you. The classic study design is called double-blind placebo-controlled withdrawal trial, which foresee an open label running phase of 18 weeks. And then the responder, according to the classic JIA American College of Rheumatology 30 criteria, have been randomized in a double-blind fashion, either to continue with the drug or to be switched to placebo. The flare patient drop out from the study and had the possibility to enter the long-term extension, as well as
those who did not flare and did arrive until the end of the phase of the double-blind part 2 portion of the trial. For upadacitinib, these information are taken from clinicaltrial.gov. The population is the same. This is the sample size, and the study foresees a 7 days treatment per cohort plus a longer term extension. Again, here, like for all phase 1 study, the primary endpoint was pharmacokinetic, safety, and tolerability. This was an open label sequential multiple ascending dose trial, so a little bit different from the one I presented a couple of slides before, but the concept is indeed to concentrate on pharmacokinetic and to allow all these chronic patients to enter the long-term extension. And finally, for the phase 3, I will move more rapidly, same population, resistant to conventional biologic DMARDs, similar duration to the other phase 3 trial I presented, same primary endpoint, and same study design, which was again the classic double-blind placebo-controlled withdrawal trial that I presented with a little bit more detail a couple of slides before. In summary, as you have seen, despite the availability of several biologic DMARDs for the treatment of JIA, there are still some unmet needs for the treatment of these children. Indeed, this is reflected from one side by the off-label use of biologic DMARDs. From the other side, to the barriers which are associated with the use of these drugs. And in particular, for some of these, the majority of the drugs which are currently administered by the injection route, the pain associated to the administration of the drug. Also, in the final part of the talk, we revise briefly potential new treatment for JIA, and in particular the class of JAK inhibitors, which are drugs with a different mechanism of action. These are indeed small molecules which could be administered orally, and these drugs are currently under investigation for the treatment of polyarticular course JIA. Thank you very much for your attention, and now we will move to the question and answer session with all the speakers. Thank you. Okay, I think now people could listen to me. We are live with all the speakers, and we could move rapidly to the discussion phase. And I will start with Dr. Lovell, and there is a question from you. And what about, you think, could be other endpoints of interest to be used in future clinical trials?
Thank you for the question. It's very important, I think, that we include some of the patient-reported outcomes that were so nicely shown earlier in this talk, especially the ones that are of very high interest to families, such as fatigue. We currently measure pain, which was also an important issue, but fatigue is not a measure we've assessed in clinical trials. And also, I think it's important to measure effects on children's ability to do the normal things that they like to do. Our functional assessment is focused on very routine physical measures, but children are more interested in more engaging things, such as the ability to do sports and clubs and things that are important to them. So we should evaluate those measures as well in clinical trials to get a more robust measure of the overall impact of treatments on measures that families tell us are important to them. And I think the other measure we really need to focus on is measurement of clinical and active disease through the JDAS. We've incorporated that in some more recent trials, but I think that's the important outcome in terms of disease activity we should focus on. Thank you, Nicola.
Okay, thank you, Dan. Let's go backward. Laura, now up to you. So the first question is from Dr. Fernando Garcia Rodriguez, and he's asking, do you think findings from patients' perspective could be generalized to different regions, social and economic environments?
Great question. Difficult to answer. So I think the only way we're going to be able to answer that question is to do much bigger pieces of work speaking to our patients across the globe. And I think that pediatric rheumatology were very well set up to be able to do this because we have very active patient networks, for example, through the breast community. I think it's very likely that there will be significant overlap between the outcomes that are important to patients in different places, but I'm not in a position to say that with any certainty until the next piece of work is done.
Okay, thank you very much, Flora. Let's move to Alessandro now. So Brian Feldman and Uda Nassi ask this specific question. In the treat to target recommendation, principle A relates to shared decision making. How should one deal with a patient or a family desire to have as the target no side effects and no medication, but rather herbal medication? Even in less extreme situations, how should we factor in the family in shared decision making?
So, thank you, Brian. As usual, this is a beautiful and difficult question. So, there are many answers. First, we have to share the decision-making process. So, you have to find an agreement with the family and combine your point of view with the family's point of view as usual. Shared decision-making means that you have to find the targets, to share the targets with the family, say that we are going to escalate the therapy if we don't meet the targets. What is the target? As Flora has pointed out in her presentation, we have seen that we have the well-being bus in the JDAS. Well-being means everything for the patient. Means the active disease, but also means therapy compliance. Patient can be in remission but cannot be happy because he's taking one injection of anahero per day. So if we want to keep the well-being VAS in the JADAS and keep the JADAS as a target for our treat to target strategy, we have to be aware that the point of view of the patient and his family in how the course of the disease is going is very important. This is one point of view. We can have another point of view in which we can ask the patient about disease activity, and we can think that asking for disease activity is something different than global well-being. We have in the JAMAR, that again Flora has shown in her presentation, the JAMAR has a VAS, as a scale for disease activity, and the patients are quite objective, especially those patients who have a story of the disease, and they can differentiate well-being, general well-being, and disease activity. So it is something we have all to agree. If we want to keep the JADAS as it is, as a target, the JADAS includes the global well-being of the patient, and we have to take pros and cons of this.
Okay, we have about 2 minutes, few minutes to go, so I will restart the round. So then, do you think current clinical trials are sufficient to assess the efficacy of therapeutic option under development, and in particular to overcome what are the patients' unmet needs, or do we need something else?
Well, I think we've seen data in this presentation about one level of unmet need, which is children continue to have active articular disease despite current treatments with polyarticular disease. We need to, I think, address that unmet need by exploring new mechanisms of action of treatment, such as the JAK kinase inhibitors, which we've just started, but there's many JAK kinase inhibitors being developed. So we need to embrace this therapeutic area to see if we can provide benefit to these children with polyarticular disease who are failing our current treatment. The other area of unmet medical need is treatment specifically for children with psoriatic arthritis and ERA. And currently we have no treatments that have been tested in these subgroups of patients specifically, even though there's an increasing number of treatments focused on psoriatic arthritis and spondyloarthropathy in adults. So we really need to, I think, explore more effective treatments for children with axial disease, which hasn't been the focus of our trials to date.
Thanks, Dan. Another question for Flora from Dr. Islam Al-Abadi. This is a long question. So, are you aware of any current initiative to evaluate if improvement in the captured JIA prompts resulted in better score in the parent-patient domains as compared to traditionally collected outcome measures? This might help to obtain additional funding from healthcare funders to address the most important domain, physical, social, and emotional aspects.
Okay, thank you, Islam. So I guess the original purpose of the prom that we developed was to empower our patients and their families to articulate quite complicated and often distressing impacts that GIA can have on their quality of life, things that are really difficult to talk about in clinic, and things that we as physicians are not necessarily skilled at addressing. I guess physicians can only really know and help things that the patients tell them. So it's a little bit about empowering the patient to have a voice. I think it would be really interesting to do a piece of work looking at how the Capture JIM prom responses correlate with the more traditional outcome measures such as the global scores. I hope they would correlate very well, and that therefore the global scores could continue to be used, for example, in clinical trials as a proxy for these key outcomes that patients are talking about. In terms of lobbying healthcare funders, yes, proms like this have huge potential in the context of, for example, national clinical audit, and that, I guess, is where we're hoping to employ them next. Thank you.
Okay, thank you, Flora. Now, the second question for Alessandro, because Alessandro, when we posed the question if we follow the treat-to-target approach in the case of little Julia, we had 95% of the people answering yes. What do you think?
Of course, it was a tricky question, and not everybody in the audience could be aware that we didn't share the decision-making process with the patient, of course. But I did it on purpose because I think that this thing is of foremost importance. And talking about treat-to-target strategies is easy. Implementing the strategy in the real life is not the same. It's not easy the same way. So I think the JDAS, coming to another question that was posed by the audience, is probably the best tool that we have now. We are quite far from having biomarkers that can surrogate the disease activity level completely, but the JADAS can be improved. We have still a lot of work to do.
Okay, thank you, Alessandro. I just make a small joke that I did not pose to you the question from the audience, which is the best tool, because in my way you are a little bit biased towards the JADAS.
The C-JADAS, which was developed by Flora.
Okay, so we are now moving to the end of this symposium with a lot of questions. Let's very, very briefly summarize what we have tried to accomplish. So we started with this functional concept of polyarticular course JAA, which has been implemented in clinical trials. Then with Alessandro, we moved to the concept of treat-to-target approach, and with the tools which are currently available to properly quantify the level of disease activity. Flora then guide us in the patient and parents' perspective with the strong message to, let's say, collaborate more and more with parents and children to develop an high-quality patient-centered care. And finally, then we look at the current use of drugs that we have available in the shelf, as well as the future possibilities to manage children. And so, and among these, of course, there is a room which is quite interesting for pediatrician related to oral drugs. So this is the conclusion of our symposia. I will remind all the participants to please complete the evaluation form that is on the right of your screen. And finally, let me thank Alessandro, Flora, and then for their wonderful presentation, and Pfizer for sponsoring this symposium. Thank you very much to all. Bye-bye.